The second presentation was a proposal. It was a CIBMTR proposal, which was co-led by myself at Hopkins and Dr. Salas, who was at Princess Margaret and is currently in Spain. But what we intend to do here is to show how haploidentical donor transplants fare compared to the traditional way of transplanting with matched-related or matched-unrelated donors in myelofibrosis. CIBMTR previously has been an excellent platform in determining that for other malignancies, including acute myeloid leukemia and lymphomas, where they have compared patients who got haplotransplants versus matched unrelated transplants with or without ATG, and showed some specific differences in these patients, which are helpful to clinical practice. We don't know that about myelofibrosis. And in a world where haploidentical donors are easily accessible, haploidentical donor transplants are thought to be cheaper compared to some other strategies. They can be done more quickly. There's always a question that comes up whether we should pursue a family donor, even though that's a mismatched donor, versus an unrelated donor from the registry. All the more important in the times of COVID, where some international donors had some challenges, even though I absolutely commend the work of NMDP in getting us through the COVID era with our matched unrelated donor transplants. And we proposed that to CIBMTR to help us compare clinical outcomes in these patients who get a haplodonor transplant versus a matched related or unrelated donor transplant. The primary outcome of the study would be overall survival, and the secondary outcomes would include some of the other clinical outcomes, including relapse-free survival, rates of relapse, non-relapse mortality, GVHD, and the cumulative incidence of graft versus host disease and relapse and survival. We added a third aim, and that was intended to address a study that was presented by Dr. Gupta, which is also a CIBMTR study at ASH, which showed that patients who get transplants with PTCI, in the reduced intensity platform, the matched unrelateds did better than haplodonors. Since the myelofibrosis cohort in CIBMTR registry is 70 to 80% reduced intensity conditioning, we thought this could be a good platform to discuss that or to address that question as well. So that is our third aim, to compare clinical outcomes of patients who get a PTCI-based transplant, but haplodonor versus matched-related or unrelated donor. We have around 177 patients in the registry who got a haploidentical donor transplant for myelofibrosis. These would be patients who get a first transplant for myelofibrosis in chronic phase between the years 2013 and 19 and are recorded in the registry. This would be compared to matched unrelated, which were 921, and matched related, which was 542. Overall, otherwise, from a baseline patient perspective, a lot of these categories were fairly similar, including the transplant details, such as the graft type and the conditioning and so forth. And with that, we will compare overall survival in these groups. We'll address a list of patient, disease, treatment, and transplant-related variables in the univariate analysis. And by backward elimination, we'll remove or include patients include variables that have a p-value less than 0.05 on the univariate, and we'll include them in the multivariate analysis. And for the last aim, which is to compare outcomes of patients who undergo post-transplant PSI-based transplant, haplo versus matched donor, we'll compare the 177 haplo PTCI-based patients versus the 120 PTCI-based matched donor transplant patients, again, mainly focusing on overall survival as the outcome. We hope CIBMTR will consider this study because this has been an important question that has come up over and over again. Very important question for patients with myelofibrosis. A very difficult study to do outside of CIBMTR because, myelofibrosis transplants are fewer and far between at all centers. So we need a consortium such as CIBMTR to address this question.